fourth panelist, Stacy Miller. She's a physiotherapist at BC Children's Hospital in Vancouver. She's a coordinator of Child Health BC Hip Surveillance Program for children with cerebral palsy. She completed her graduations and master's program in physiotherapy from University of British Columbia. She will be talking on a role of therapist and knowledge translation in hip surveillance. Over to you, Stacey.
Thanks very much, and thanks very much for the invitation to present. I'm very happy to share our experience here in British Columbia, and always happy to speak to a group of physiotherapists. And I think I'm hoping to inspire you with our experience here in British Columbia and really the very important role that physiotherapists have played in the success of our program. So just briefly, my objectives today will be to describe the role of physiotherapists here in British Columbia as part of hip surveillance, and to share with you some of the strategies that we used to make sure that we were able to educate therapists across our province, and what impact that's had on the children here in British Columbia. And so you saw these slides from Kishore's presentation. And so really the development of guidelines for hip surveillance is really just the first step, but then really trying to figure out how do we make these guidelines work within a healthcare setting is really the challenging piece. And so Kishore and I are here in British Columbia in Canada, the westernmost province. You can see in red here on this map of Canada, and we're located at that little yellow star in Vancouver. And so not centrally located within our province, which spans about 1 million square kilometers. So fairly vast in size, not a huge population. We have about 5 million people. And we're spread out through both urban, rural areas. And so the last stats I could find were about 60% of our population lives in urban areas, and the remainder live in smaller communities, with about 14% living in what's considered rural areas of the province, where the population in their kind of local area would be less than 1,000 people. So we're spread out over a very big area. And so our challenge was really to figure out a system where we could reach all corners of our province. And so Kishore talked about that meeting that we had where we brought everybody together and developed guidelines. And we did that a second time and looked at, okay, we've got these guidelines, but now what do we do with them? And we had a few key questions. And one of those, which I'll focus on today, is who's going to find these children and who's going to complete the clinical exam? And then we went over kind of what that clinical exam was. Knowing GMFCS levels, doing the clinical exam of, measuring hip abduction and understanding children's gait patterns. Physiotherapists in our province identified themselves as being really the best ones to complete that clinical exam. They have the skills to do that. And I certainly would agree with that when you look at the skill sets of the different healthcare practitioners in our province. And so physiotherapists are located in centers across the province, in child development centers and in schools. And so you can kind of see the placement of therapists across the province. And so this was really our network of trying to educate all of these people across the province. As well, you can see the blue stars. We have a couple of orthopedic surgeons that are outside of BC Children's Hospital that we work closely with as well. But really our key when we first launched this program was how do we access really the knowledge of therapists across our province. And so one of the first things we did was really to look to see what was people's knowledge to start with and how supportive were they? And we were very happy before we even launched our program to know that therapists were highly supportive of doing standardized monitoring for hip displacement. And likely this has a little bit to do with the fact that we'd done some education prior to this, but important that we had the support of therapists across the province really from the start of the program. But we also looked at kind of what was their typical practice. And so we asked people, do they typically identify GMFCS levels? And a lot of people did. There was, a small percentage that, if you look at that first row there, so, less than 30% were really not doing it all that often. The vast majority were. And then who routinely completed a clinical exam, and that was kind of across the board. A lot of people were not routinely looking for hip displacement as part of their kind of routine care. And so this meant to us that we had a lot of work to do in kind of changing practice with these therapists. And that was just. And then as far as kind of their confidence in knowing how often the child should have a clinical exam or an X-ray, again, that was kind of just across the board. There was no kind of real consensus on people feeling comfortable or confident in that, but fairly confident. The last row there is how confident are you doing hip abduction range motion? And so not surprising, most people were fairly comfortable with that measure. So we also asked people how they wanted to learn about the program and what our requirements were. And there was really a lot of different ways that people wanted to get information. So a website, in-person workshops, an online learning module was a popular one. Being contacted by email and having somebody to contact, as well as things like instructional videos and webinars. And so we were tasked really with trying to figure out which of these or all of these would we best use. And so we did do a very multifaceted approach in order to reach as many people as possible. And so I'll show you some of the things that we've created over time, and all of them are freely accessible, and we'll make sure that you have the links for everything following this presentation. So on our website, a therapist can access all of our resources. And some of the most popular, I would say, is this online learning module. So it tells you, you can go into it and learn about everything from hip displacement. You can see the topics along the top here. So understanding hip displacement, our consensus. For those that aren't comfortable with GMFCS level, you can go in and learn about GMFCS level, and there's videos which show children at different levels. There's the group 4 hemiplegic gait patterns. So again, videos showing children with all of the different hemiplegic gait patterns. And then also links to additional resources. And that, again, just shows kind of some of the different components of one of the sections there on our consensus. We developed a number of materials, so booklets that explain everything that you need to know about hip displacement. Kishore showed some of this images related to how children should be positioned for imaging. So that was developed and is sent out to families when they're due for an X-ray. Posters so that child development centers can put those up just to, again, kind of spread the word. And really, I think that's an important piece to understand, is that therapists really became our way of accessing families. And so we also developed materials for therapists to take to families to explain why is hip displacement a problem, and why is it important for their child, so that we were providing them with the resources that they really needed in order to communicate with families, because they really were kind of our key link in reaching people. So that first survey that I showed you was in 2015. We repeated the survey in 2017, a couple of years after we'd implemented kind of first push of the program. And so in the green is the 2015 results, and in the purple is the 2017 results. And you can see here on a number of, well, all the measures that we did here, that, confidence increased in identifying children. Here, more familiar with the surveillance guidelines, confidence in GMFCS levels, and so on. And so really this kind of demonstrating that those knowledge strategies that we used were successful. And if you are interested at all in more related to those two surveys, those results, as well as the surveys that we used, are available open access on this publication. And again, we'll make sure that you have these links if you're at all interested. So where are we today? So we've, as Dr. Mulpuri said, we're almost 5 years into the program. We've now enrolled over 1,100 kids in the program. And we've had over 150 different physiotherapists that have identified children in our province and enrolled them in the program. And when you look at that as part of kind of the overall of who has identified kids and sent them to us, the vast majority is from physiotherapists. And so they really have been the backbone and what's made our program a success. And speaking of that survey, we have done a third rollout of that survey. Again, kind of just constantly checking to see kind of how we're doing, as we know that therapists change, and wanting to make sure that we're kind of keeping hip surveillance at the forefront of their mind. And you can see here again, the 2015 in green, the 2017 in purple, and 2020 survey in blue, that we've managed to continue to increase confidence in identifying children that require hip surveillance. And I won't go over these graphs, but again, kind of just showing that we've maintained or improved, again, some of those kind of clinical components that are important as part of hip surveillance. And so I would say for lessons learned for us, as I said, and it was the title of that paper that's been published, is that really physiotherapists have been key to successful hip surveillance here in British Columbia, and having a targeted but customized knowledge translation strategies are required for therapists. And I've put in here for families and physicians as well, because while this, talk I have focused on therapists, it did kind of, as we rolled out, it did kind of come to realize that we need to not just focus on therapists, but provide some from education for families and physicians, but recognizing that really therapists were our drivers but behind our success, and that really multiple knowledge translation strategies are required. And as I said, that continuous need for education is required. So I thank you for your time.
Okay. Thank you, ma'am. Thank you for such a eye-opening topic on importance of hip surveillance in terms of physiotherapists. Yeah, we'll quickly move on to next panel discussion now, which is last discussion on cerebral palsy hip. I welcome Dr. Ashok Johri, sir. He's a well-known pediatric orthopedic surgeon in Mumbai. He's currently working as a director of pediatric orthopedics in Nanavati Hospital, Mumbai. And he started his training in this field in 1980s. So he's having huge experience in same field. I welcome you, sir. He will be talking on a hip surveillance status and surgical interventions in Indian perspective. Over to you, sir.
Well, thank you, Sachin, and I'm thankful to all of you for inviting us and having this session on CP hip surveillance. I think it's a very, very important topic, and the previous speakers have highlighted the importance of this. They have made my job considerably easier, and I will just touch on what is relevant to us in our situation. There are three areas which I would like to talk about, and that is the need for hip surveillance in India. Then the Indian Cerebral Palsy Hip Surveillance Program, where are we? And the surgical issues facing us. So we know this is a maxim, if you take it as a maxim in your practice, I think it's a very, very useful maxim, that every cerebral palsy patient has an abnormal hip unless it is proven otherwise, and this is way back in 1962. This paper actually stressed the importance of examining every cerebral palsy patient for abnormality of the hip joint. So the question, is there a need for hip surveillance in India? Why hip surveillance in India? Well, 35% of the population with cerebral palsy will have hip displacement. Early displacement is silent. Natural history is one for worsening. There's hardly any case which has improved. It goes down the line and actually worsens over a period of time. Early treatment will preserve hip health and give you a better health-related quality of life. And by surveillance, we can eliminate hip dislocations altogether. The Indian scenario is alarming. Our population is 1.3 billion with a 3% prevalence of cerebral palsy. The cerebral palsy pool is 2.5 million, 2.5 million. When we say that 35% of these people will have hip instability, it equals 800,000 patients. 15% of this pool will develop hip dislocations, and that would mean 15% of the cerebral palsy pool, and that would mean about 3,75,000 hip dislocations a year, which is a very, very huge number. I mean, that's the prevalence of the problem of hip dislocation. Now, early detection and aggressive management of the unstable spastic hip is the key. This is important. This has been stressed. The Reimer's migration index has been stressed. The percentage by which the growth plate or the femoral head is outside the acetabulum in relation to the total width of the metaphysis of the femur is the Reimer's migration index. And this is a very, very important index in relation to cerebral palsy hip surveillance. Now, if you watch this particular patient who presented in January 2004 with a mild instability of the hip and see the sequence of events as time progresses down the scale, in a year's time, you see that about 40 to 50% of the femoral head is outside the acetabulum. No treatment, things worsen 2007, 2008, 4 years later, more than 50% is outside the acetabulum. More importantly, you see that the femoral head has changed shape from spherical to becoming flat on the inner side. Kishore emphasized that hip displacement increases by GMFCS level from 1 to 5, so that the group 4, the GMFCS level 4 and level 5 become important markers for hip surveillance. I think it becomes very, very much more important in these patients because the incidence of hip instability is as high as 69 to 90% in these cases. Now, hip pain is directly or indirectly related to the migration percentage. When you have migration of the hip, there is reduced hip range of motion because of a number of reasons, and the hip pain may be related to the reduced motion or indirectly related to the migration percentage. More the migration percentage, more the pain. We have something known as end-stage hip disease. This is in functional weight-bearing adults with cerebral palsy. It results in a loss of gait and mobility. So when you have a stage like this, where the femoral head is completely eroded because of the forces between the femoral head and the acetabulum and non-centration of the femoral head, you get a complete loss of the cartilage, and that signifies a end-stage hip disease where the hip becomes very, very painful and the person loses his day-to-day activities of ambulation or of doing other functions because of the pain which he has, because of the deformities which he has, and because of now the lack of ambulation. So our aim should be to prevent. As they say, an ounce of prevention is worth more than a pound of cure. So this becomes very, very important for all those in this field, of cerebral palsy, and especially in relation to our country. The second part of my talk is the Indian Cerebral Palsy Hip Surveillance Program and where are we? I think this is important for everyone. We want to give you information on this because this is something which is going to come up, and this is where we require you to be with us. And as was mentioned by Stacy, I think therapists become the keystone, who can actually deliver such a program in its entirety. When we talk of an Indian surveillance program for the cerebral palsy hip, what do we have to do? Our experience is similar to all those other programs in other parts of the world. We need to get together all stakeholders. So all those who are involved with cerebral palsy need to come together. We need to thoroughly review the literature and the existing systems of surveillance. We actually need to ask questions and establish consensus by the Delphi method. We need to frame the guidelines. And finally, the most important part is the implementation. The stakeholders, as you know, are the patients, the professionals, the organizations, and the government. All these are stakeholders. The professionals, we require a multidisciplinary base to represent all streams dealing with cerebral palsy. And our program has rehab therapists, orthopedic surgeons, neurologists, pediatricians, developmental specialists, physical medicine and rehab specialists and special educators, etc., all those who are involved, professionals with cerebral palsy, are important to be represented in the surveillance program. A number of organizations are involved, all sorts of associations who are responsible for teaching, training, education, dissemination of information. They're all involved, whether it's the Orthopaedic Association, whether it's the Indian Association of Physiotherapists or the Occupational Therapy Association, the Pediatric Orthopedic Society of India, the Association of Child Neurology, the Physical Medicine and Rehab Specialists. And I must acknowledge all the help we've been getting from the BC Children's Hospital, Kishore and Stacy's group, who have been supporting this sort of setting of a surveillance program in India. This is called the Save the Hip program. Now, the phases of the project, we passed through phase 1, which is a thorough literature review. We are on phase 2, where we discuss and come to a consensus via the Delphi process. The phase 3 is the post-consensus documentation and literature and creation of educational tools. So we have done a thorough literature review, 8 modules pertaining to different facets of cerebral palsy. 80 papers have been reviewed. Each reviewer, so each member of the team has reviewed at least 2 papers per module, which underwent final reviews comprising the 2 reviewers and a mentor. So multiple times the papers have been reviewed. We come out with our comments and seen what is more relevant to our condition, our situation. We are now on phase 2, discussion, Delphi, and finally reaching a consensus through the Delphi process. We've been repeating rounds till the consensus is reached on questions. There are questions on which we reach an instant consensus. An example is here. So APU is recommended for within a standard position to identify hip displacement. I think most of us would agree. There's no controversy there. But when should a child be referred to an orthopedic surgeon? When the migration percentage is 25% or 30%. Opinion is divided. We say we reached a consensus when we have more than 80% in favor of one particular proposition. Now here, because of different reasonings, one would think that 25% may be good because by the time the patient is referred and reaches a pediatric orthopedic surgeon, it takes a long time. So there are some controversies which are being resolved by second round, third round of the Delphi process. The phase 3 will be actually writing down the guidelines and creating educational tools like what Stacy showed you, And the final and most important is implementation, getting it through the government, getting it through our patients, getting it through the people who are involved, professionals who are involved, educating and doing a lot, which I believe will extend over a long period of time, if we have to be successful. The last issue, which I'm going to briefly touch upon, I know you're not surgeons, so I'm really going to be very superficial here. We're talking about surgical issues which are facing us. Now, this is a good schema. You have hip surveillance. Hip displacement reaches 30%. You can go in for muscle surgery, or sometimes you may elect to wait and watch, but muscle surgery, if definitely the clinical examination shows that the muscles are tight, then you can follow up and do surveillance following the surgery. If the hip remains stable, you can continue with the long-term follow-up. If still there is hip displacement and it's progressive, then you need to do bony surgery and then again continue in the surveillance program for a long-term follow-up. The treatment recommendations, soft tissue surgeries when the migration percentage is about up to 40%, bony reconstruction where the migration percentage is more than 40%. So some authorities believe that surgery should be done as soon as subluxation of hip appears. Our own personal experience is that the situation does remain. Mild subluxation can be monitored over a period of time. Progression can be slow in some cases and fast in other cases. So you need to establish the phenotype of that particular patient. Is he a fast progressor? Is he a slow progressor? Can we afford to wait and watch, or can we go ahead with the surgery? The waiting and watching approach is really to convince the parents and to create a background that surgery may be indicated in this patient. The levels of intervention, we say, preventive is soft tissue release before we do any bony or reconstructive surgery. Then there is reconstructive surgery, which is bony surgery usually, and finally salvage for painful arthritic hips. So this is the treatment algorithm. Preventive surgery is mainly muscle surgery. Reconstructive surgery is bony surgery like a varus osteotomy or a pelvic osteotomy. Salvage surgery for pain, where we excise the proximal femur, or we do a valgus osteotomy combined with a femoral head excision, as was shown by Kishore. Now, the same patient which I showed you earlier, in 2008, they agreed for the surgery, and then this is the type of surgery we had to do. The magnitude of surgery increases with the displacement. We had to do a soft tissue release, a open reduction, a femoral shortening, a femoral osteotomy, and acetabular surgery to sort of reconstruct this particular hip joint. The effect of hip reconstructive surgery on the health-related quality of life, well, it's a positive effect. Migration percentage has an inverse correlation with the health-related quality of life outcome measures. Conversely, if you do reconstructive surgery, the hip improves and the health-related quality of life of children with hip instability improves. So
Ashok, sir.
there are, yes, I'm finishing. That's the last one.
Okay.
There are sort of graphs, and people have done the child scores after the reconstructive surgery to show an improvement in most parameters. So to conclude, hip migration is a significant issue in cerebral palsy. The non-ambulatory pool has significant hip and spine related problems. Surveillance programs are a must to reduce morbidity, and early detection and early management will reduce the magnitude of surgery. So thank you very much for your attention. We would welcome questions.
Thank you, sir. We would we had a lot of questions to be asked, but we are lacking behind with time. But we have one question, like how we'll take only one question for today. Like how surveillance guidelines are formed. Are they different for different countries? It is for all. Like every country is having different guidelines for this surveillance, or are they same?
Kishore, go ahead.
Yes, I think the different countries have slightly different modifications based on their health system and what works for them. But if you ask me, largely they're very similar. I mean, the age at which you may start and the frequency may slightly differ depending on the healthcare system. To give you an example, we chose probably when we would probably discharge GMFCS once from our surveillance program based on when they would lose some of their funding to go into another model. So, but largely they will be the same with slight differences, but you do have to take that into account.
Then we'll conclude the session. I would like to thank all the panelists and Scientifica team and Team Sancheti for organizing such a wonderful event. Thank you, everyone.
Thank you.
Thank you, everyone. Thanks.
Thank you, everybody.
Thank you.
Take care and be safe.
Thank you.
Bye-bye.
Bye, everyone. Bye-bye.